Ahmed, thank you very much for the kind introduction. I'm delighted to be here. Medical device reimbursement, honestly, it's a ton of fun, and I find it absolutely fascinating. It's one aspect of what I do in my consulting, but it really is one of the most interesting parts. For those of you who were at the last lecture with Jason Parker, he focused on the regulatory aspect, which has very clear guardrails. And one thing I think you'll take away from this lecture is that there aren't such guardrails with reimbursement. It really is a very multi-pathed challenge. So I certainly find it very, very interesting. So with that, I would just add one thing on the land acknowledgements. You know, I'm a bit of a student of history, and I would suggest that the examination of our past is essential to understanding ourselves as Canadians. And I'd certainly encourage you to pick up a copy of books like An Inconvenient Indian by Thomas King, very funny and uncomfortable read. Braiding Sweetgrass by Robin Wall Kimmerer, and Clarence Louis, chief of the Osoyoos First Nation in BC, just put out his book called Res Rules. That's another really good book. Certainly, you know, land acknowledgement is an important piece. I think all of us re-examining our history is an important piece as well. And those are three books that I would recommend. The other thing that I wanted to put on the table is please feel free to contact me at any time. I'm guessing that the audience is made up of a lot of people who either are in the midst of commercializing a medical device or interested in the possibility of commercializing a medical device, and that's what I do. So I'm very happy to offer some direction and some guidance on those ventures. So that my contact information is here. Feel free to reach out to me. As we go through the lecture, use the hands up function. So I'll be able to see that you have a question, or as Ahmed suggested, you can put it in the chat and he can direct the questions to me. You know, this virtual stuff is it's a challenge. I'm going to do my best to make this interactive, but I hope that you will feel free to and I certainly encourage you to jump in and ask questions as we go through, because this can be a complicated and nuanced area. With that, let's get into medical device reimbursement, and I want to start with the core takeaway. What's the one thing? What's the one thing I want you to remember if you remember nothing else? I'm going to put up here on the left, but there's a picture of a butterfly, and I wonder if anyone can tell me what the significance of that butterfly is. Any thoughts? Anybody? We got to kick off this interaction here. So somebody give us, Alexander, what do you think?
So I'm going to go with, I mean, there's a lot with monarch butterflies that you could go with. Yeah, Jamie. But with the butterfly effect, how sometimes a small change can lead to like drastic unintended differences in a different area.
Alexander, perfect. That's exactly what I was looking for. And my take on that from a reimbursement standpoint is to understand your impact. Reimbursement, the successful path to reimbursement, I should clarify, is based entirely on understanding what your impact is of your device. So we'll be talking a lot about that as we go forward. Understand your impact, and there's the patients, of course, but there may be a nurse in an operating room, or you may be impacting a hospital administrator's budget. There may be an intersection with a policy advisor in the Minister of Health's office. What motivates these people, and how does what you are doing impact them, and either create a positive for them or a negative that you may have to deal with. So understand your impact. That's the key, the core takeaway for today. So I think you're aware, Ahmed mentioned it at the beginning, lecture. We're going to have about an hour for a lecture, and hopefully some questions in there as well. And then we'll take a break, and then we'll have a bit of a workshop session. So for those who will stay for the workshop, and let me just, while we are here, I will just drop the document. Will I drop the document? Oh, shoot. I thought I had it right here. And now I don't. All right. So on the break, somebody remind me, I will drop the, oh, here it is. Okay. So this is the, all right, so I'm dropping the document in the chat now. So for anybody who wants to join us for the workshop afterwards, that's the document that we're going to base the workshop from. We're going to be talking about eye stents. And these are a really interesting, interesting medical device innovation. They are a stent that goes into the eye. And these are the 5 questions that we're going to get you to work on. Then we're going to come back as a group and ask. So where does it fit into the HTA 2x2 matrix? We're going to be talking about that health technology assessment matrix. What's the impact on stakeholders? What are your key messages for the stakeholders? What actions would you take? And what are the challenges in getting your stakeholders to take those desired actions? That's where we're going to focus. Again, this is all about understanding your impact. And then, of course, what are you going to do to bring those groups and those people on side? So that is part 2. So just wanted to give you a bit of a primer for that. Now, we're talking about value for money, of course. So where do you get great value for money? You get great value for money at Food Basics. But we're actually going to talk about a different store. It's called Reimbursement Basics. And this is what we're going to go through today. This is a huge area. We're just going to touch on the surface over the next hour and hopefully stimulate your curiosity to find out more, or at least give you some direction in terms of next steps. Let's start with the basics. What is a medical device? So a medical device was probably described, for those of you who were here at Jason's lecture the last time. A medical device is outlined very well, 200 or so words in the Food and Drug Act. To me, I have 7 words that describes what a medical device is, and it is simply, it's used to help patients, but it's not a drug. Nice, simple explanation. If you want the full details, you can go to the Food and Drugs Act. So this means that everything from a toothbrush to an N95 mask to software that performs diagnostic images analysis for making treatment decisions with acute stroke or a transcatheter heart valve, all of these things are medical devices. And the picture here on the right of the screen shows a few more, some Band-Aids and rubber gloves and tape, and all of that stuff is considered a medical device. So it's quite a large category. Now, who is this guy? Any guesses? I can give you some hints if you want. He was a Baptist minister. Alexander, I can see you talking, but you're on mute. I don't know if you're talking to me or somebody else.
Oh, I'm discussing with myself how I don't know who it is.
Yeah, okay. Okay. All right. Second guess, second clue. He's a Canadian politician.
We have a few people posting in the chat. Tommy Douglas.
Tommy Douglas. That's exactly right. He's well known to be the grandfather of Kiefer Sutherland from the TV show 24 and others. But perhaps he's more well known for being the father of Canadian Medicare. This guy is primarily the reason that 70% of all medical devices are paid for by the public purse. But that also means that 30% are paid for by other avenues. So we're going to talk about all of those avenues. And I think it's also worth putting the question on the table. I don't know how much time we can spend on this, but if you have a medical device, you're going to want to ask yourself, do I want reimbursement? Because there are positives and negatives to getting reimbursement. So I want to talk a little bit about those in a minute, but first let's talk about what is reimbursement. So can someone define for me what reimbursement is? What are we talking about here? Reimbursement, anybody? And Alexander's talking to himself again, telling himself that he doesn't have an answer. So
Oh, no, I know I have an answer. I mean,
oh, you do?
like,
Okay.
Reimbursement. I was telling Jamie, I think that Jamie Block knows the answer and he could speak up too.
Oh,
To call people out specifically.
Thanks, Alex. Appreciate it.
So,
It's getting paid back for a service or a good or anything for which you're entitled for repayment.
yeah, I think that's good. Alex, you were right. Jamie had a very good answer. For me, it's somebody other than the patient that is paying the bill for this medical device reimbursement. What would be a downside for the somebody other than the patient paying for a medical device? We're talking governments, we're talking insurance companies potentially. What's the downside of having them pay for the reimbursement? Any thoughts? Everyone always thinks that, we got to get reimbursement, and it's true. If you want to be successful with a medical device or a drug for that matter, reimbursement is key. But is there a downside to be aware of? Any thoughts?
They decide what to pay for, when not to pay for.
I think that was Miriam, and then Dominique had her hand up. So Miriam, say that again.
They decide what to pay for, what not to pay for.
They absolutely. So you can get a hard yes, you can get a hard no. No, wait a second. We had somebody with their hand up that disappeared. Dominique.
Yeah, I was just kind of thinking along the lines that it would deter any funds from other governmental projects. If you're using a lot of funds towards one device, then those funds can't be used to other means.
Yes. So governments have to make choices. No, absolutely. Absolutely. Lisa, any thoughts as to why reimbursement might not be a good idea?
So if you're talking about the patient, perhaps depending on the cost of the device, it might not entice them. If it's a very expensive product, they might not see the benefit and won't pay. Whereas if you have someone that is willing to foot the bill, then they might be more willing to use and purchase a device.
Lisa, you're 100% correct. I'm going to turn the question slightly though. If we are the medical device company, what would be a downside for government paying for our product? So the yeah, Jamie?
Perhaps are only willing to pay a lesser amount than if it was coming straight out of the pockets of the end consumer.
Right, 100%. So and I'm talking just straight from a business perspective. If you have a large organization that is purchasing, use a consumer example. If it's Walmart, for example, the price you're going to get per unit is going to be a lot less. And so that is a factor in your business decision. And there is this business aspect, because if we can't be commercially successful with our innovation, then the innovation doesn't continue. So, but for the most part, reimbursement is what you're looking to get, because as Lisa pointed out, there's going to be more inclination to use the medical device if it's part of a package that the government's paying for, as opposed to a patient paying out of pocket. Avery, did you have a question or a comment?
Yeah, I have a question. Would that be kind of comparable to wholesale? You know how when you buy things in bulk and a lot of units at once, it's kind of like each unit will cost a lot less.
Yeah, 100% analogous. Yes. And there are mechanisms within government and group purchasing organizations, which we will get to, that specifically drive down the price of medical devices. They're purchasing a lot. They want a good deal. Exactly correct. So assuming that we do want reimbursement, and that is, for the most part, what is desired, and so the question is, how is this achieved? Well, here's the model that I've developed and that I follow. It's not a path to reimbursement, but rather it's a self-assessment tool that allows you to analyze where you are, allowing you to build a plan and fill in the gaps. So I'll walk through each of these. So at the bottom here, you have Health Canada approval. Again, that was the lecture last time, getting the approval from Health Canada. Health Canada says, yes, your medical device is safe and effective, and you can now sell it in Canada. So we layer on top of that something called health technology assessment. And we're going to be having some detailed conversations about what the heck that means. It's not required formally for all medical devices, but it is something that you need to have be putting some thought to. And then on top of that foundation, we have the 4 pillars of reimbursement. So the first on the left is the value offering. That's a so what? Who cares? For example, there's a company that has a new HIV test kit. Who cares? There's lots of HIV test kits. Yes, but this HIV test kit is actually the first home kit. And so a patient can take this home and do a self-assessment, and they don't have to feel any of the social pressure or the embarrassment, or they can just do the test and they can get the result. Okay, now we're talking something interesting. Now there's value. The strength of the data is the next pillar. So we need some proof of the value. So I say this new HIV test kit is going to reduce the social stigma of maybe getting a test, or the concern that a patient might have about their privacy. So that seems like a logical argument, but where is the proof? Have you done a study? Is this a published paper? What kind of quality of evidence is it? So the strength of data is going to be the second pillar that holds up that reimbursement roof to allow you to get reimbursement. The third one is level of advocacy. So who's standing on your side? For example, is there an MPP, a member of provincial parliament that perhaps suffers with the disease that you help with? Or is there a patient group or some group that is willing to advocate on your behalf? And the last one is the support or alignment with government priorities. A number of years ago, the Ontario provincial government was trying to eliminate the wait list for hips and knees, orthopedic surgery, and so anything aligned with helping them speed that up would be positively aligned with government priorities. Yesterday was Rare Disease Day. And the government has a strategy of sorts. If you have a medical device that aligns with rare disease, they've indicated that this is an important area for them. That's going to help strengthen your reimbursement profile. And so, like any kind of structure, you may have 1 or 2 pillars that are stronger than the others, and you can still achieve reimbursement. That's why I say it's not a map. It's more of a tool to self-assess. Dekra, I hope I'm pronouncing that correctly. You have a question? And you're on.
Unmuted. Yeah, I realized that. I had a question actually about the strength of data. How does it play differently in the context of reimbursement versus Health Canada approval? Because I would have not imagined it to be there. I would have thought it would be kind of strength of data, Health Canada approval, and then the rest.
Yeah, it's a great question, and it's one of the big challenges that pharmaceutical companies and medical devices have, is they design their clinical. It's getting better, but they design their clinical programs to get Health Canada approval. So everything that they do is focused on showing that the product is safe and effective. Great, we've got approval, we can go sell it in Canada. Oh, but nobody wants to pay for it. The difference, and we'll get into the health technology assessment in a moment, but there's a big difference between saying your drug is safe and effective and saying that your drug offers great value for money. Those are two different things and requires a different line of study. And Decker, we'll talk about health technology assessment, and if I haven't answered your question directly by then, come back to me and we'll talk more about it. Jessica, you have a question?
Yeah, so I find this the topic of reimbursement super interesting. I just want to clarify that I understood correctly. You're saying that as an entrepreneur who's come up with this device and has passed Health Canada approval, and you want to kind of launch it in the market, but you realize that patients need financial help in being able to afford your device. So as an entrepreneur, it's your responsibility to go through the process of making your device reimbursable through the government. Is that correct?
That's correct. Yes.
But okay, so that kind of brings me to my follow-up question. What if in situations, because there are such situations where the entrepreneur or the private sector may not have an incentive to go through the process of applying for reimbursement, if the demand for the device is strong enough and the price of the device is just right to the point where it's still pricey, but the patients are desperate, so the demand isn't affected too much by the price. Am I making sense? So like sometimes there's that fine line where the price
Jessica.
isn't great, but at the same time the demand isn't affected by the price, so that like inelastic demand essentially.
Yeah, you've got some economics in your background.
Yeah,
You're precisely right, Jessica, and that's what I was referring to before with that fundamental question: do you want reimbursement? Because if it's going to cut your price by 50%, maybe that's not what you want. And there are various factors that will go into whether you want to go down that reimbursement path or not. We don't have time to go into all of those today, but you're exactly correct.
I guess so my final question to that is, are there any does the government have any stronghold on determining whether something must be reimbursable for the sake of the patients? So are there any kind of policies per se where the government says, no, you got to at least apply to make this reimbursable for the sake of the patients?
Yeah, it's a great question. And you have to go back to the Canada Health Act. We didn't have time to go into that today. But in essence, one of the pillars is that if it is medically necessary, the government pays for it, and it is illegal to charge anything additional for it. So you do have to be conscious of that line. Most of the time, you with a medical device, you can be on whatever side you want, but in some circumstances, you may be locked into being medically necessary and therefore being part of the system. So
thank you so much.
It's one of the as I said, there are many different paths to reimbursement, and that's one of them that you kind of have to assess along the way.
Yeah, I'm glad there's at least something. So
yeah, which is why, again, this is not a roadmap, because a roadmap would be wildly complicated. This is a way of self-assessing to say, okay, who are we? What do we have here? And what's the potential? So yeah, good question. Let's take a step back and have a little bit of context here. So medical device, this is some data from 2019, hasn't changed significantly though. You can see at the top here, Canada is about 2% of the global market at $7.3 billion. And you can see that it's made up of a number of bits and pieces here. Other medical equipment is a big category. That includes things like wheelchairs, ophthalmologic instruments, anesthesia apparatus, dialysis, blood pressure monitors, endoscopy, hospital furniture. All of that is in the red. Diagnostic imaging is a big piece. Consumables is a big piece. And you can see that the both are pretty close in terms of their percentages. You got a global market about 410 billion US dollars. And the US is, nobody will be surprised, the largest market, 43% of the world's market. That's a little under drugs. Drugs are somewhere up about 50%. They're an enormous market for healthcare because they didn't have a Tommy Douglas. So let's go into this model a bit further. We're going to talk about the first two, value offering and strength of data. And those are a little bit two sides of the same coin. Value offering is the so what. What are you doing for patients? What are you doing for physicians? What are you doing for the healthcare system? Where's the value in this medical device? And then the other side of the coin, which is, okay, show me, where's the proof? Where's the data that says this? And all of this goes into the health technology assessment recommendations. So that value offering and strength of data feed into your health technology assessment. Now, for the mathematicians in the room, this is going to be fun. So this is and let me say that some people study this for a lifetime. This is their job. This is their career. So again, just skimming the surface. But health technology at its assessment at its heart can be boiled down to this. So we have the two axes. The x-axis is the increasing difference in effectiveness. So you have your product measured by effectiveness for A, and you have the B product and the effectiveness for B, which is what's on the market today. So is there a difference? If you are more effective than what's out there today, then you're going to be on the right side. And if you're less effective, then you're going to be on the right side. Then you're less effective. You're going to be on the left side. Then there's on the y-axis and the increasing differences in costs. Same principle. The cost for your medical device is and the difference between that and what is the standard of care and what else is on the market. If you are more expensive, you are going to be on the top side of the matrix. And if you are less expensive, you are going to be in the bottom side of the matrix. So where do you not want to be in this? Anybody? Where's the worst place to sit? Or conversely, where's the best place to be?
The worst place to be is the upper left.
More expensive, less effective. Yeah, that's a pretty tough sell. You got a less effective medical device than what's out there, and we're going to charge you more money. That's going to be a fun conversation. Kamal, do you want to give a shot at the best place to be?
It's in the other end. It's on the right downside, like the right down.
Yeah, it's on the right. You definitely want to be more effective. And you could argue that you want to be more effective and cost more, or you could argue that certainly if you're a little more effective and you cost less, oh my goodness, that's a great value proposition. That's a nice, easy story. We're going to charge you less. We're going to have better outcomes. So that's the matrix. And then what the health technology assessment folks do is they just draw a quick line right through the matrix, and they say, oh, if you're on the top left of that line, you are not cost effective, and if you are on the bottom right hand line, you are cost effective. It's a little bit arbitrary, but that's the mathematical model that they use, and that's turned into something called an ICER, an incremental cost effective ratio. So if you hear somebody talking about an ICER, don't get nervous. That's all it means. It's simply a ratio with the difference in cost over the difference in effectiveness And that is a key part of analysis for formal health technology assessments. There's also cost benefit analysis, which is a measure of just dollars. There's cost utility, which is the non-financial. Here's another term that you're going to hear a lot if you get into health technology assessment, is quality adjusted life year. So that's the measure of the value of a year of your life with perfect health. Anyone want to take a stab at what that's worth? Dekra?
No, sorry, I had a question. It
Sure.
wasn't. I was going to ask, so this is when you have two things to compare. What if you don't have a reference? Because you're always comparing A is better than B, or did I get that right?
It's true. It's true. There aren't, if you are so fortunate to be a product which is treating something of significance and there's nothing else out there, then the comparator will be will for argument's sake be nothing, and therefore the impact that you're going to have is significant. You'll likely be deemed a breakthrough product, and so then the conversation is a little bit different, and frankly a little bit easier. So your effectiveness ratio is going to be massive. Now your cost ratio will certainly be more as well, but yeah, does that answer your question?
Yeah, thank you.
Yeah. So how much is a year of perfect health worth to you guys? Anybody want to hazard a guess? Give me a dollar figure.
$30,000 to $100,000, depending on the jurisdiction.
Oh, Alexander, that's pretty good. Is that a guess, or you've been doing some research?
We've done a little work in the area.
Okay, good. Anybody else? So it varies. It's completely arbitrary, and each jurisdiction will put a threshold. The most common ones that I've seen is somewhere between 50,000 and 150,000. So if you are going to cost more than 150,000, you're not going to be deemed effective. So yeah, we don't need to go into any more details on that. Like I said, this is a whole area of university study and whole departments in companies. Jessica, yes.
I was just wondering if you could clarify what the difference is in terms of effectiveness and benefit. Would the benefit be referring to the financial
Yeah,
versus
yeah, there are different kinds of analyses, and that's all I wanted to highlight. A cost benefit analysis just measures money.
And but effectiveness talks about the value to the consumer.
The effectiveness, yes, is the efficacy of the drug. It's the impact on the patient.
I see. All right, thank you.
Exactly. Okay, so who does health technology for medical devices? Oh my God, there's 43 different public institutions involved in medical device HTA. There's probably more by now. Any fans of Gravity Falls? So if there are any fans of Gravity Falls, I hope there are a couple. You can tell that I have a son who's between 8 and 12 years old. So Grunkle Stan has a really cool place, and on his property he has a bottomless pit, and the HTA medical devices are a little like that. There's a bottomless pit of medical device HTA groups, and the reason is that it's hard. It's very, very difficult to do an health technology assessment on a medical device. So there's lots of groups that do it. Nobody does it particularly well. And the other issue is that it's not mandatory. So if you have a medical device, you're going to have to figure out, okay, do I want reimbursement? If I want reimbursement, should I do an HTA? It's expensive. It's time consuming. It's risky. But in some instances, they will require you to do a formal assessment. And in some cases, it will speed up your reimbursement. So again, this is another another split in the road, you may have to take a left or a right. So it's important to make sure that you're assessing whether you need to do that assessment or not. I will say that there are two main groups that do health technology assessment or do it well. One is CADTH, which is the Canadian Agency for Drugs and Technologies in Health. They are very, very good at health technology assessment and drugs. They are just getting into medical devices. But as I say, medical devices are tricky. The other problem with medical devices is that there are thousands of them that are approved every year. So the quantity is difficult to manage as well. Health Quality Ontario is another organization. And so if you are looking at health technology assessment, there's another group that you may want to look at. There are other elements that impact the value for money that you need to be aware of. Things like, is there a current fee code? So doctors are paid for fee for service. So if they put in a hip, they get a fee. If they see you for a checkup in your office, then they get a fee. So if you are bringing a medical device that doesn't fit nicely into a fee code, one, you're going to have a problem with physicians using your medical device, and two, you may have some resistance in government paying for something additionally that they weren't paying for before. So that's something to be aware of. Is there extensive training required to use your medical device? Are there infrastructure requirements? I worked for Alcon at one time, and we had a really remarkable laser for eye surgery. One of the challenges we faced is the thing was massive and required a special cooling and required a special room. There was literally a room that they had to build in order to have this laser. So that required additional costs from an infrastructure standpoint. And is there an impact on someone's livelihood? The reality is that if you are replacing radiologists with your new medical device, perhaps a scanning app or something, you may expect to get some resistance from that group if you're eliminating their livelihood. So that's something to consider. Again, going back to the core takeaway from today's lecture, which is understand your impact. If you understand your impact, then you will be able to address each of those points, or at least mitigate the negative that might come from those. So now we go back to our model here, and we talk about level of advocacy. So can someone give me some examples? I gave a couple before, so maybe there's some others. Who would advocate for the reimbursement of a medical device? Can I get some examples? What kind of groups or organizations might be interested in picking up your cause and saying, yeah, you really, this medical device needs to be paid for sure? It's Avery.
I don't know if maybe I'm going down the wrong route, but insurance companies, does that count as reimbursement?
It counts as reimbursement, Avery, but they would be what I would describe as the payer. So they're the ones that are actually paying. And so certainly in some cases, they would be very interested in having your medical device reimbursed, because it might get people back to work sooner. It may lower costs to the employer somehow. So they're certainly enthusiastic about reimbursing your medical device, but they ultimately are a payer like government. So what I'm thinking is, who is going to go to government? Who's going to go to the insurance companies and say, you need to be paying for this? I mean, obviously we are as the company, we're going to be saying it's the greatest thing ever. But who else that's not part of our company will be? Alex, you got some thoughts?
Yeah, so I mean, I think that like patient, there's a bunch of people mentioning several things in the chat that I think are like accurate. Like there's patients themselves, and I think also a patient's family will often, be advocating for, a device to potentially be covered, but you have larger, medical groups that maybe align around a cause that would, I'm not sure what to call those, if it's like a medical association that would kind of, bring a bunch of people together and go and campaign government.
Good call. Those are two good ones. So patient groups and physician organizations, and there are a bunch of those. There's usually one for every therapeutic area, and there's the Ontario Medical Association, and there's, so there's those are two good ones. Any others that jump to mind? Anyone? Well, these are the broad groups. So to my mind, a stakeholder is any person that's affected by or that influence could or could influence the decision of or the actions of a payer. So these include employees, suppliers, competitors, customers, consumers, advocacy groups, activists, the community, different parts of the government, although government will be making the decision. The government's a big piece, so different aspects of the government can be an important stakeholder for others. Investors, professionals, academia. To simplify this a little bit so that we can understand our impact, I developed this what I call a wheel of influence, and in the center are the decision makers, and then 6 broad groups of potential stakeholders that will influence the decision makers. So we have economic stakeholders, so for example, like the Ontario Chamber of Commerce, or a group like that's more, the Canadian Chamber of Commerce, more sort of the business side of things. There's the political side, which are politicians and advisors. And we'll talk a little bit about that, but within each Ministry of Health, there's a political side with the politicians and advisors, and then the other side, which is the bureaucracy. It's the other side of government. On the bottom, you see key opinion leaders and healthcare professional associations. Alex, this is what you were talking about. Individual key opinion leaders are important, though. So a key opinion leader is a physician who others look to when they are deciding what course of treatments that they would favor in the use of their patients. So these are the guys that are standing on the podium at conferences and doing lectures at conferences and so on, and publishing papers. There's the media, which can be very, very powerful. And Alex, you also mentioned patients and patient groups and individual advocates. So we'll talk a little bit about these. And I call it a wheel of influence because while they all potentially influence the decision maker, they also can influence each other. So the media can influence the politicians and advisors of the bureaucracy. Key opinion leaders can influence the patient groups. Patient groups can influence the media. So it really is an interconnected web of stakeholders when you're looking at who might advocate for the use and the reimbursement of your drug. Just a word about media. If anyone recognizes this picture, you're going to date yourself. You'd be probably over 45 years old. This was from a Maxwell tape ad. Anybody recognize this? Is it anybody, or is it just me? This is a great ad in the late in the late 70s for Joseph. You look like you might. Yeah. Okay, good, excellent. Okay, good. I got one.
Yeah, I hear you.
Excellent. So this to me is a good picture. The media can amplify the message, but boy, you got to be cautious. And I would recommend, if you're going the media route, you should seek professional help on this and most things, because that can be a double-edged sword. So let's look at the last one, which is the support and alignment with government priorities. And so I want to talk a little bit about government. So who's this guy? Anybody know who this is? Oh, come on, somebody's got to know who this is.
Yeah, that's Doug Ford.
That's Doug Ford. Of course it is. That's Doug Ford. Who's this guy? Yeah, that's nobody knows that. That's Steve Davidson. You know who Steve Davidson is? He's the Secretary of the Cabinet. And the Secretary of the Cabinet is an incredibly powerful person in the province of Ontario. He's the head of the bureaucracy, but nobody knows who he is because he's the head of the bureaucracy. So a quick little delineation on political versus bureaucratic. So the political side, you got about 1,000 politicians and staff. You got about 5 or 10 people who are actually governing the province. The bureaucracy is 60,000 plus. They're both divided into ministries. So each ministry will have a political side and a bureaucratic side. The politicians, of course, every 4 years, we replace or try to replace them. Bureaucracy has jobs for life. The primary role of the political side is the policy, and the primary role of the administration, primary role of bureaucracy, rather, is the administration. It's the implementation of policy. We see the politicians in front of the camera all the time. Bureaucracy stays in the shadows. And I have power with a question mark. So it depends on the politicians and the bureaucrats, but they certainly both share power. The reason I make this delineation is because if you are aligning with government priorities, you need to understand where it sits. Is this more of a political play? Is it more of a bureaucratic play? If it is one or the other, which ministry is it? Is there a combination of ministries? And who you want to talk to and who you approach is going to vary depending on the medical device and the particular issue. So all that to say, it's important just to remember the political side, bureaucratic side, when you're deciding the support or alignment with government priorities. So then if we have our pillars in place, then we're going towards a reimbursement. And we're running a little short on time. So got a few more slides to go through that I think will be really helpful. This one I really like. This was from a May 17 document called Advancing Healthcare in Ontario. And it is a great map of how purchases are made within the hospital setting. So the bottom you have in the blue, you have the indirect commodities. So this would be like chairs in a waiting room or things that don't directly impact care. There's a huge amount of purchasing in indirect commodities. If we take a step up, then you get into clinical commodities. So gowns, masks, sutures, that kind of thing. Then you get into medical technology, which is the stuff that you guys are more involved in. So this might be, MRI machines or some software to help with diagnosis. And then there's the innovation, the truly innovative piece on the top. The reason I like this is because then it cross divides it into the 3 different blue colors. So blue is purchasing for price. Those are true commodities. If you're selling a Band-Aid, it's pretty tough to try and differentiate yourself on anything other than price. The light blue is purchasing products and services, and that's evaluated by price, cost, value. That's the whole balance of cost versus value. And then the blue is where they're purchasing solutions. So I think I can't recall who it was that asked about, what if there is no comparator? So here's where these things sit. There is no comparator. This is a breakthrough. This is something that really is going to make a difference. And there's nothing else to compare. The hospital is purchasing solutions. So if you can put yourself in this map, I think you'll have a better understanding of your approach to getting reimbursement. So understanding the hospital, most medical devices are purchased through the hospital. So you're looking at about 1,400 hospitals in Canada. The vast majority of their purchases will go through something called buying groups. And so we'll want to touch on the buying groups for a little bit. Buying groups are third-party organizations that create volume of purchases so that they can get a better price. So if you have a medical device, you're going to want to get to know group purchasing organizations. This is another chart that I really like because it outlines the money flow. It's quite complicated, but you've got the vendor on the left, and then there are intermediaries here in the middle, and then you have actually the people that are procuring, so hospitals, long-term care, the community access care, the LHINs, different agencies. These are the ones that are actually procuring, and so there is this middleman concept that's important to highlight. But I would circle these, put these two circles on, because the vast majority of purchases are going to go through shared services organizations and group purchasing organizations. And again, vast majority of purchasing is going to go through hospitals and long-term care. So the important thing from your perspective, again, is understanding where you sit on this map as a medical device, and understanding your impact within that scheme. So with a hospital and achieving medical device reimbursement within a hospital, it's going to be really important to identify a nurse or a doctor champion to advocate for your clinical benefits. That really is step one for any medical device that is going to be used in the hospital. And most hospitals will initiate a clinical evaluation. And they can do that before they make a commitment to purchasing. So that's a really good step on the path to reimbursement. You're also going to want to get to know the C-suite because they are going to be stakeholders in this path. Additional approaches to hospital, you're going to want to think about patient advocates, early adopter hospitals. There are probably teaching hospitals as a generalization will be more early adopters than others. The hospital and clinic pilots are a good way to get in the door. Partnering with a larger healthcare organization like University Health Network, for example, in Toronto. Strategic procurement, and where you're creating a partnership and targeting potential funding programs and opportunities is another approach. I touched on group purchasing organizations and shared service organizations. I don't think I need to say anything more. I will highlight two names though, MedBuy and HealthPro. The vast majority of purchases go through these guys. They're huge. So again, if you have a medical device, you're going to want to think about approaching MedBuy and HealthPro. There's also a direct government reimbursement. So you will find that sometimes the Ministry of Health does some direct purchasing. Remember, I talked about the fee schedules as being important. And then there are some alternative payers. So there's private healthcare organizations, there's allied care professionals, private insurance companies, we touched on a little bit, direct to consumer, regional health authorities, long-term care facilities, spelled incorrectly, sorry about that, hospital charitable foundations, and private donors. So that's a very speedy path through reimbursement. Again, the most important piece is understanding your impact. If you understand your impact, you're going to understand where you fall in some of these schematics and who you are going to want to talk to, and get on board with your advocacy. So thanks for your time and attention. We have a few minutes for questions. So I don't know if there are any. We had lots of great questions during the session. So before we take a break, are there any other questions?
Yes, I do have a question.
Yeah, Raphael?
Yes, sir. First of all, thank you. It was a very nice explanation of the overall system. But where those financial institutions fit into like a DLL, like banks that finance the whole medical device environment?
Well, medical device companies are financed, I suppose, by the banks, but I think it's more the venture capitalists, certainly for the smaller companies, and then for the larger companies who are public, it's going to be it will be shareholders that will be financing. So I'm not sure.
Sorry. You did great, but let me try to rephrase that. So my question is, if you already have a device on the market and then hospitals want to purchase your device, but they don't have the capital budget right now, so they go for those banks to help them to finance and to do the lease or something like this. How these ties all together with this new technologies?
Oh, in terms, I see what you're saying. The banks helping the hospitals finance the purchase of equipment.
Exactly.
Yeah, I that's not very common. It's far more common is support from government or foundations, charitable organizations, high net worth donors. It depends what you're talking about. If you're talking about sort of, a new $500,000 MRI machine, then that's, probably going to be the path. If it is a smaller device that's used on, hundreds of patients in a surgery, for example, you're going to find that the hospital will have to figure out how to pay for it within its budget. And then we get into the question of trade-offs, which somebody raised it at the very beginning. But banks, I don't think are really a factor.
Got it. Thank you,
Alex.
Yeah, thanks. So when you kind of like showed the network of kind of spider webbing of how the actual to the shared, from the hospitals to the shared services groups and to the actual vendors, that's how the money flows. Is there kind of like one or a few major systems that are used for that money flow, or is it like also kind of this big network of different systems that this money is passing through? Because you also need some kind of infrastructure to facilitate this reimbursement, right?
Yeah, I don't have if I understand your question correctly, I am not familiar with the finance side and how payments are processed. Is that what you're getting at?
Yeah, I didn't know if there was kind of a separate system for how payments were processed, or if kind of reimbursements had their own system that they moved through that was kind of developed by the government, and everyone who was working kind of tried to go through this reimbursement system.
Yeah, yeah, as much as I can say on that is that the group purchasing organization will negotiate the price, and then the hospital or the procurement group here will be the ones that will pay the vendor directly. I'm not sure if that answers your question or does so in part, but that's how that works.
It answers it in part for sure.
Yeah.
Okay.
Okay. Any other questions? All right, Ahmed, maybe over to you. I think we can take a break there, and whoever wants to come back for a bit of a workshop should still be in the chat. The link to the document, and we can have that conversation in about half an hour.
Awesome. Thank you so much, Mark. That was a very insightful and engaging session. Thank you very much for that. And yeah, let's take the break and come back here at 6 p.m. I'll be posting the link again for the case study in the chat.
Okay, and then Ahmed, do you want to hang on a bit, and we can just sort of organize how we'll do the
Sure, absolutely. Yeah, I'm here. I'm not going anywhere.
Okay.